Hello, welcome to the course on Polymeric Biomaterials. We are in the first week of lectures, and the theme for the first week is Introductory Concepts, wherein I will aim to provide you with the background and motivation that is required for the course, and broadly try to understand why this course is of relevance in today's world. We will also aim to provide you with some concepts that will be required for you to appreciate all the other concepts that you will come across in the rest of this course. So, with that aim in mind for introductory concepts, we will first begin in today's lecture with biomaterials over the years, and the goal here is to look at how did we get here today in terms of biomaterials, where did we start from, and what does the future look like. And what we will do in today's lecture first is the course is called Polymeric Biomaterials, and it will help us if we can dwell a little bit on that word biomaterial itself and try to understand what it means in today's context, and then look at historical perspective, more specifically looking at different periods in history broadly classified into 3 periods for different reasons. And we will look at the developments in each of these periods and then finally see where we stand today and how many of those developments that occurred over those 3 periods are still helping us today. And then we will end this lecture with looking at what we mean by generations of biomaterials and also the market potential of biomaterials, just to get a sense of why this field is so important. We will first start with a very simple, very basic question. We will ask, what is a biomaterial? Now, we will revisit this definition over the course of this week again and again, and throughout this course to try and understand different dimensions and aspects of what biomaterial is. But for today's starting point, we will simply define biomaterials as materials that are used to interface with biological systems to evaluate, treat, augment or replace any tissue or organ or function in the body. So, right away you see that there is a therapeutic component, there could be a diagnostic component, or there could be a supporting component. And we will look at multiple examples of each of these things throughout this week. One thing to note here is that the word bio in the word biomaterial itself does not necessarily indicate that the material is of biological origin. The word bio here must be interpreted in the context of the biological interface, that the material ultimately will come in contact with the biological interface or a host or cells or tissues, and that it is meant for interacting with a biological system. So, that is the context in which the word biomaterial must be interpreted. Now, because we are looking at the biological interface and the interactions therein, you can have synthetic and natural materials that are widely used as biomaterials interfacing with what we would broadly classify as a complex biological system. Now, this could be a host, it could be an animal, it could be a human being, or it could even be cells or tissues if you are testing some things in the lab, right, in the initial stages for example. And in many of these or almost all these cases, there are going to be physical, chemical and biological interactions, and note the two-way arrow here. The interactions are not one way, but they are two-way. The intent of the design of the biomaterial as it is going to be put or implanted in the body is for it to perform a specific function. So, this is going to have an effect on the host, but because you are dealing with living systems here, the host in turn is going to have an effect on the material itself. It can do a lot of things to the material, and both of these together will eventually determine the success of any biomaterial that is used in a clinical application. You might have also heard of this phrase called blood contacting devices. when often used in the context of biomaterials. So that is one way to think about many of the biomaterials that we will discuss in the course, where they are directly coming in contact with blood when they are eventually implanted. Biomaterials is a very wide-ranging interdisciplinary field that involves inputs from multiple professions. I have only listed as an example 4 professions here. One is the engineer. We have listed chemical engineering here, but you can have mechanical engineers, electrical engineers being involved. So, they are largely involved in the design and testing of the physico-chemical properties of the biomaterials, for example. And they often have to work in close collaboration with material scientists who may be synthesizing the material, who may be looking at things like degradation of the material and what happens to the degradation products within the body. And both of those have to interface with biologists who will in turn look at cell biomaterial interactions and try to understand how biomaterials affect cells and how cells or tissues in turn can remodel biomaterials, for example. And all of these disciplines ultimately have to interface with clinicians, because ultimately these materials are intended, remember, for implantation or interacting with the biological system. So, if they have to be eventually deployed in a clinical application, clinicians have to come into the picture, and all of these other disciplines have to now find a common language that they can speak to with the clinicians. And so you see immediately that it is a very complex and very wide ranging diverse field with a lot of different disciplines being involved. Now, one question we can ask right away is this a new field that we are looking at today? As we will look at very quickly, when we look at the history of biomaterials, this is by no means a new field. We have much newer ways of thinking because of the advent of newer technologies, but you will see very quickly as we go through the history of biomaterials, a lot of the design paradigms that have been used over many years are still relevant even today. So, what we will do is quickly take a look at the evolution of biomaterials from a historical perspective. Now, I think it is important for us to look at historical perspectives for any course, not just this course, for any course that you take, for at least 2 different reasons. One is, it tells you compared to where we are today, where we were and how everything has evolved, how science has developed over the years, over decades or centuries, and how technological advances have brought us to where we are today, so that you get a larger sense of appreciation for the concepts and the technologies that we use today in the broader context of the historical developments that led to them. The second important reason, and I think the more important reason, is history often tells us a lot about the contributions of a lot of the great men and women of science who have helped develop any field, in this case polymeric biomaterials. So, we start to now appreciate their contributions more and more as we look at the historical perspective. So, in this lecture we will focus on quite a bit of the historical perspective to get a deeper appreciation for these contributions. So, we will first begin with period 1, or what I call period 1, and this is a very long period going all the way from starting with say early antiquity to the period right before the wars. That is what we call period 1 here. And we will first begin with the example of surgical reconstruction here around 600 before the Common Era, where Sushruta is supposed to have repaired earlobes with cheek skin and is said to have pioneered a rhinoplasty technique using flap of the forehead skin, and shown here is the schematic representation of that technique, where the after making the measurements here, the distal flap is now sutured into place for a nasal defect as shown here, and the forehead defect from which the flap is taken is closed permanently. So, you see there are no materials being implanted here in the sense of how we would think of biomaterials today. In today's parlance, this is what we would call an autologous graft, where the patient's own tissue is used for reconstruction. And Sushruta is supposed to have been one of the pioneers in not only doing this, but also carefully documenting this. We next move forward in time. We are looking at around 200 in the Common Era, and we are looking at a wrought iron dental implant in a corpse from France, whose pictures are shown here. Now, there are some very interesting things about this implant here, where the radiograph or the X-ray shows a perfect fit into the socket, suggesting that that this implant, the way it was designed, may have been a deliberate design. And because it is a perfect fit, there is also a suggestion that the broken tooth that had come out could have been used as a model or as a mold to create the wrought iron dental implant. And evidence also suggested that this implant had osseointegrated. Now, this is a word that we will look at in more detail as we go through the course, but for now, in the interest of picking up jargon early on, when you come across a word like this, it is instructive typically to break down that word into smaller words and then try to piece together the meaning in the broader context of whatever you are studying. So, here osseo simply means that it is related to bone, and the word integration means that the implant here, in this case the wrought iron dental implant, had healed well, and bone had actually formed around the implant without intervening soft tissue. That is what the word integrated means in this limited context. This, of course, it is not like this person would have surgically implanted it. This was perhaps done through impaction, but still provides the first evidence of someone deliberately putting something into the body where the material also had integrated well. Of course, you would not be using wrought iron dental implants in today's world, but again this is very interesting to look at in historical context. Then we move forward, and around 600 in the Common Era, we are looking at Mayans who are fashioning nacre teeth from seashells, which had also osseointegrated. Now, nacre is called the mother of pearl. It is a naturally found material that is a organic and inorganic composite. The organic part is typically a protein, and the inorganic part is a calcium carbonate. And in today's day and age, you have a lot of people using nacre inspired composites, because nacre itself is very strong and resilient, and for its exceptional mechanical properties, people find a lot of inspiration from nacre to design composites. What is also interesting here is the fact that it had osseointegrated. All that shows here, the key take home from this slide is to realize that these things simply show the body's ability to adapt to an implanted foreign object. That is a very important idea here. As we move forward, we are still in the period before the wars. As we move forward to around the 1800s, early 1800s, and now we are looking at dentistry and orthopedics again. We are continuing that thread from the previous slide, but here we are looking at Levert, who is implanting metals like gold, silver, platinum, etc. in dogs and trying to understand in vivo bioreactivity. Now, what bioactivity means, etc., we will look at in far more detail in subsequent lectures. But what is important to note here is this represents a shift in the mindset, going from implanting whatever you have around you and making it functional versus a clear hypothesis driven study here, where Levert is implanting these metals to specifically study in vivo bioreactivity, and this is possibly the first scientific documentation of metal compatibility. And if you move further in time, we have nickel plated steel bone fixation plates that are used, and even further in the early 1900s, right around the war period or right before the Second World War, you are looking at Vitalium alloy, which is a cobalt chromium molybdenum alloy, which is very well known for its corrosion and wear resistance even today. So, you see, we have gone from implanting metals like these to the use of alloys, sophisticated alloys in dentistry. And another very important area that has historically been very significant for biomaterials is this area of contact lenses, and that is also something we are looking at in the period before the wars. I am giving you a snapshot of the significant developments here. In 1632, Descartes proposes water-filled glass tubes with a lens attached as a lens. Now, Descartes is someone whose name you might immediately recognize if you have some exposure to philosophy. He is the person who is associated with I think, therefore I am. He was a philosopher, but he was also a man who wore many hats. And in this context, Descartes' proposal, although very interesting, was very impractical, because with this kind of a device, the person can't even blink if you are putting the lens this way. And then you move forward, say around 200 years, and then you have another person who is suggesting eye molds for fitting these lenses. So, if you have eye molds, then this person is suggesting that to get a good fit, can you have molds where the glass can be made to fit well or snugly, such that the person who is eventually wearing it is able to use that glass reasonably well. But it was not until around 1860 or so where Fick first tests glass contact lenses on humans and animals, and these are what we would call scleral lenses, which is just placed on the eye, and it is believed that he even tested it on himself. Now, in today's day and age, you can't imagine this at all. You would have to go through a series of regulatory approvals before you can test something in animals, leave alone humans. But again, we are looking at the period in around the 1860s, where it is very significant to note that there was somebody there trying to think about how to improve contact lens designs. And if you are wondering if this Fick is related to another Fick that you might be familiar with, of the Fick's law of diffusion fame, your intuition is indeed right. He happens to be the nephew of A. E. Fick, who is famously associated with the Fick's law of diffusion. So, in this contact lens example, we are seeing a clear progression in what we would call design today, although it was probably not called that back then, going from 1630s to 1860s. From there, we now move to the period 2, which is the period around the wars. Now, the two wars, the World War I and World War II, brought in excessive destruction and a lot of misery, but they also led, interestingly, to exceptional industrial growth and large scale manufacture, a lot of which was driven primarily by a need during and around the wars. So, there were a lot of newly developed high performance metals, ceramics and plastics that were used. And notice the word plastic here, as we will see later in the course, that is one type of a polymer or one specific property of a polymer, although in today's world, when you commonly use the word plastic, you typically refer to a certain kind of plastic, but plastics are also in common parlance used synonymously for polymers, which are much broader. So, that word plastic there, put a pin on it, we will come back to it later in the course. What we mean here is there were a bunch of polymers that were developed around the world wars. And the philosophy here during the wars especially was not to develop new materials per se for clinical or biomedical applications, but to repurpose industrial materials, believe it or not, for biomedical use. And a lot of it happened to be serendipitous, as we will see very shortly. Some examples of those include titanium, Teflon and nylon. In this period around the wars, we will look at three important milestones that are of extreme significance even today as a means to understand how war-related industrial development led to industrially important high-performance materials being repurposed for clinical applications. And the first of those developments or milestones happened in 1938 when Carroll and Lindbergh published this book called The Culture of Organs. Now, in this book they address a lot of very futuristic ideas, but one important idea or paradigm that is of relevance right now to us is they address the design of pumps for organ perfusion. So, the idea is to use a device such as this, which is simply a Pyrex glass based device that can now help perfuse organs outside the body, or what we would call ex vivo. So, removing the organs outside the body, how do you keep them alive? And the Carroll-Lindbergh perfusion pump was the precursor to that idea that eventually led to what we would today call the heart-lung machine. In the Carroll-Lindbergh pump, the idea was to take the organ out and keep it alive outside the body by perfusing blood through it. And the design for the heart-lung machine which we use today was largely inspired by the Carroll-Lindbergh pump. In fact, the heart-lung machine today is used when cardiac surgery happens. The heart itself beating can interfere with how the surgeon operates on the heart. So, the heart-lung machine temporarily takes over the function of the heart so that the surgeon can operate comfortably. And these developments that we have today, of course, are far more technologically advanced than the Carroll-Lindbergh perfusion pump, but the idea was seeded in 1938. From here, we move on to another very important milestone which happened in around 1949, where Harold Ridley implants the first plastic intraocular lens. So, we have looked at contact lens earlier, glass being used on top. This is an intraocular lens which goes inside. And how he came up with this idea is also very interesting. Now, imagine you are in the 1940s and what is it that tells you then that plastic implantation in the body can be tolerated by the body? That is a very revolutionizing idea, but also very controversial idea. What would have told you that, right? And how Ridley found that out was also very interesting. It was purely serendipity. So, Ridley, it turns out, was treating pilots who had flown these Spitfire Hurricane fighter jets during the war, and it so happened that the canopies of these jets were made from ICA perspex, which essentially is plexiglass or polymethyl methacrylate. It is a polymer, and what had happened was, because the eye was easy to observe, Ridley was inspecting the eyes of these pilots, and he found that the sharpenel or shards of plastic from the plexiglass from the canopies had lodged into the eyes of these pilots and had healed without significant issues. What I mean by issues here is, no permanent harm seems to have been done, and this is perhaps one of the earliest observations, formal observations of what we would today call biocompatibility. Again, this is a word we will go through in more detail in upcoming lectures, But the limited context of this topic, what it simply means is no harm was done by these shards of plastic getting lodged into the eyes of these pilots. That from there to developing intraocular lenses was not an easy journey for Ridley. It took a lot of convincing from his side for the scientific community to accept, or the clinical community to accept, that plastic could be operated, could be implanted into patients, and those surgeries would be successful. To the point now where around 30 million intraocular lenses are implanted globally annually. So, from where to where? From trying to convince an entire community of people that, look, putting in these into people would not harm them, to an entire multi-billion-dollar industry. Okay. Again, it goes back to the fact that he was a very, very careful observer. Just that one observation made a very big difference of the fact that these plastic shrapnel from these canopies that had lodged into the eyes of these pilots had healed well. The next very important milestone, that is the third milestone in that period around the wars or right after the wars, is Shanley deploying a metal plastic hip successfully. This is also a very interesting story for how he came up with this. So, it turns out that the state of the art then was metal on metal implants for the hip. So, these are entire implants that will replace the function of your hip for patients who have either fractured their hip or who are undergoing other kinds of bone related issues. Nevertheless, the idea was to implant entire metals that will take over the function of the hip. So, the state of the art then was metal on metal implants, and that would lead to issues like metal ion leaching, you would hear squeaking and so on. So, Shanley was already on the lookout for a good alternative to metal on metal implants, and legend goes that there was a gear salesman who was selling novel plastic gears to a technician in his lab, and these were made from these ultra high molecular weight polyethylene type of polymers, and apparently the salesman was pitching that these had very good wear resistance and abrasion resistance, and that clicks somewhere for Shanley, and he comes up with the idea of using ultra high molecular weight polyethylene for the hip implant liner. And it was not that this was something that he was doing for the first time. He had already tested another polymer for this before he had heard about ultra high molecular weight polyethylene, and that was this polymer which is PTFE. Commercially, one commercial version of that you will know as Teflon. So, he had already been testing polymers for this as an alternative to metal on metal implants, and he had already tested PTFE, but PTFE had failed quite badly and performed very poorly because it was leading to a lot of these articulating surfaces, and that led to a lot of debris coming out, and that is not something you would want in the implant at all. So, he was already on the lookout for an alternative, and the moment he hears the gear salesman making this pitch, something clicks in him. So, this is a very good example, as Pasteur said, of chance favoring the prepared mind, and that leads Shanley to develop a device that integrates multiple types of biomaterials, a metal along with a polymer, into one device. And for many years that remained the gold standard, the Shanley implant, and even today that serves as the gold standard or the inspiration for all the newer designs that have come thereafter. Ultra high molecular weight polyethylene, a cross-linked version of that, is used even today in many of these implants. And shown here is a radiograph of one such implant, 22-year follow-up with no complications. Again, you see, just as with the Ridley example, there were two things that were important here. One was there was already a need, he was already looking for something based out of a need. But more importantly, apart from serendipity, it also so happened that because there was a need, all that it required for him to come up with this innovation was to connect dots. And that's a very interesting lesson that we can learn from here for how innovations happened in the past. From there, we move to the third period, which is the period after the wars, around a 40-50 year period from the 60s to the 2000s. And here we have a series of different developments that happened. We will go through them quickly without getting lost in the details of each of them, because many of them we will look at in more detail in later lectures, but this is just to give you a snapshot of how these developments happened over the years. So, in the 60s, we are looking at the example of reconstruction, where the state of the art then was simply to inject silicone gel for breast reconstruction, and that led to a lot of inflammatory reactions to the point where it had to be banned in some of the states in the United States back then. And an alternative that came up as a result of innovation was silicone gel filled PDMS based implants. So that was a significant improvement over simply injecting silicone gel. You also have in the domain of organ function the Scribner or Quinton Scribner Teflon shunt for blood access. Again, this was a very important development for patients with kidney failure, for example, where a picture of that implant is shown here, where you have a Teflon U-tube for access, and you have a silicone rubber tube where the blood flows, and you place the shunt between the artery and the vein, and the idea was you can remove the blood, send it through dialysis and resend the blood back to the patients. It was also very important to note that this the inventor refused to patent it, because he believed that patenting it would prevent access to this shunt for millions of patients who may be suffering from kidney failure issues. Of course, we have come a long way. Dialysis machines, the way they work, the designs have been significantly improved, but again, in historical perspective or historical context, in hindsight, this was one of the earliest developments where the idea was seeded. So that's sort of what we are trying to ask here. Could we have come up with these things back in the 60s? That's the question that we should ask, and then we get a much larger sense of appreciation for what these great scientists were doing back in the day. Moving forward, again in the 60s and 70s, you have the development of bioglass. Now, bioglass is a silicate based glass with calcium oxide and phosphate based ions being added to it. So, it was developed by Larry Hench, and it became very significant because this was what we would today call bioactive. Again, this is a word that whose formal definition we will look at in a subsequent lecture, but what's important to note here is this bioglass became important because it was bioactive, where it was actively doing something to promote bone healing, as opposed to titanium implants, for example, where they were largely serving a mechanical function. In contrast, bioglass could initiate new bone growth and promote better osseointegration. And 60s also were the period where this idea of delayed release or controlled release came about. And the idea was to use polymers where you can load drugs into them and release them over time. And Judah Folkman was one of the pioneers there, where he implants drug-loaded silicone tubes into dog hearts. Judah Folkman was also a very important name in cancer biology. He was one of the first people to propose the link between angiogenesis and cancer growth, and suggested targeting angiogenesis for slowing down cancer progression. Now, that was a very controversial theory back then and was not widely accepted by the scientific community. But you fast forward in today's day and age, angiogenesis and cancer is now presented in textbooks, and there are n number of therapies that have been developed for targeting angiogenesis as a means to slow down the progression of cancer. So, while some of these ideas from these great scientists may have not had wide acceptance right away, over time enormous amount of scientific evidence validates some of their theories and hypotheses. Then in the 80s and 90s, we look at Merrill and co-workers who propose polyethylene glycol, which is another polymer for multiple applications. One application that became important and is still important today is this idea of using them to create non-fouling surfaces. Why that happens, how the structure of polyethylene glycol does that, what architecture we will need to achieve that, what are the thermodynamic considerations that are involved in this specific property, all these things we will look at in far more detail in subsequent and later lectures. But for now, we will simply note that what non-fouling means is that these surfaces will resist protein adsorption. So, you can graft some of these polyethylene glycol polymer chains onto surfaces and prevent those surfaces from getting adsorbed with proteins. And if proteins do not adsorb, cells will find it hard to attach, and cells find it hard to attach. These materials can now be used for what we would call stealth applications, where the host will not even know that the material is inside, because the host recognizes foreign materials through adsorbed proteins, and if proteins do not adsorb, it is very difficult for the host to even realize that the material is foreign and that has been implanted. So, you see in one slide, we have looked at all the historically important developments that happened right after the wars, to the point where many major players like DuPont, Gore, Bayer get involved not only in research for these materials and their use in biomedical applications, but more importantly in large scale production and manufacture for clinical deployment. So, that is where we are even today. So, to summarize all of that in one quick schematic over say 2000 plus years, we are looking at wrought iron teeth or artificial teeth, moving from there to metals for hard tissue replacements. This could be titanium, cobalt, chromium alloys, etc. And then we move to bioactive materials. I gave the example of bioglass in the previous slide. You can also have bioresorbable materials, where over time, once the material completes its function, the metal will get resorbed by the body and will no longer persist. So, that is a very interesting aspect of biomaterial design that we will look at, that we will have a chance to look at in quite some detail in this course. And then to the point now today, where we are talking about biomimicry, where we are taking inspiration from nature and looking at biomaterial designs that recapitulate aspects of natural materials. For example, we have advancements in 3D printing, where you can now develop engineered tissues and organs. You can have things like organ on a chip or disease on a chip, for example, where you can do high throughput screening and testing of drugs. So, all of these developments have been made possible largely against the backdrop of innovations and developments in biomaterial production and design. So, that is something to keep in mind. 2, today, where we are now talking about implanting chips into human brains, and the goal is very specific. The goal is to help individuals with paralysis regain control over devices. So, somebody could potentially be implanted with electrodes, titanium electrodes if you will, into the brain, and they can be monitored and specifically stimulated such that now this person can have a thought, and with that they can control things like computers or even processes moving forward. So, from where to where we started looking at examples where wrought iron implant was just jammed in and it had osseointegrated and perhaps served its function as well, to where we deliberately putting chips into human brains and using a brain computer interface to help individuals who have lost limb functions perhaps even gain some of that with time. So, it is remarkable and mind boggling how we have gone from materials that were just serendipitously found to have healed within the body, where you are deliberately putting materials into the body to help someone regain control over specific actions or even limbs. We will, before we end, we will look at two aspects. One is generations of biomaterials and then the market potential. Now, throughout this lecture, we have alluded to different types of materials with different kinds of functionalities. So, we have looked at metal based, we have looked at ceramic based, we have looked at polymer based, right. Those are classes of biomaterials. But one question you can ask is, if you had to formalize how these materials evolved over different generations, we can broadly talk about 4 generations. The first generation of materials were largely considered what we would call bio-inert. Now, as we will see in a later lecture, no material is really bio-inert because you are dealing with a biological organism. Anything you put in will elicit a response. So, even if you consider the material bio-inert, it will have at least some minimal host response. These were largely industrially repurposed materials like we have seen in this lecture, and examples of that include titanium implants for orthopedic applications or silicone implants for aesthetic reconstruction. For example, post mastectomy, the tissue can be reconstructed using these silicone implants. Note here that the design philosophy is to meet desired physical and chemical properties of the device or even mechanical properties. So, the goal is largely to replace that kind of a function and not so much to elicit a specific biological response, as is clear with the use of titanium implants, for example, that largely serve a mechanical function. Moving to second generation, which is what we would call bioactive, and we have already looked at an example of a bioactive material in this lecture, which is bioglass used for orthopedic applications, where the design philosophy now is not just to implant a material to meet desired physical, chemical or mechanical properties for a device, but the intention behind the design itself is to see if you can elicit a particular or a specific or a desired biological response. In this case, for example, in bioglass, you want the material to osseointegrate through stimulating bone production around itself, and that can happen through the release of specific types of ions from bioglass, which will stimulate the bone around the implant to stimulate new tissue, such that osseointegration can eventually happen very well without intervening soft tissue. And note that a first generation material like titanium can be made bioactive if the surface is spray coated, for example, with ceramic. Moving to third generation, we have now gone to a situation where the design philosophy is to use micro or nanoscale assembly to integrate newer forms of functionality into the biomaterial. And one way to think about that is to look at self-assembling materials, perhaps inspired by natural materials which show a lot of self-assembly, and we will see many examples of that in this course, where many natural polymers, for example, show a hierarchy in structures over many length scales. and there is a lot of self-assembly that happens over these different length scales, leading to very, very interesting bulk properties. So, these could be used, for example, in stimuli responsive drug release or site targeted payload release, where in stimuli responsive drug release, the drug is not going to release continuously, but will release only when there is a particular stimulus from the microenvironment. Or site targeted payload, where the carrier releases the drug only at specific sites. So, these are newer forms of functionality that were not possible with the earlier materials. To the fourth generation, where we are looking at active and constructive remodeling of tissues. Here the intention or the design philosophy is to result in functional tissue, entire tissues or even organs perhaps, with an atypical healing response. Atypical simply means in this context that this is a healing response not associated typically with synthetic materials that you would often see. So, here one example of that I am giving, which is a very popular approach today, is this idea of using decellularized ECM for tissue repair, where the extracellular matrix from, let us say, a donor is now stripped of all the cells, but the scaffold or the construct of the tissue or the organ is retained, and that can be perfused or reloaded with the patient's cells potentially, and now you can have potentially a functioning organ where the scaffold or the construct is from one source and the cells from another source, and that can eventually lead to constructive remodeling or tissue repair. Some of these approaches have also been used for developing platforms for drug testing, for example. And we will close this lecture by looking at a market perspective, because this biomaterials field is a thriving field with a lot of potential to grow in the coming years, largely because the need for them is simply going to keep increasing. And we look at them along two categories. First is the category based on the global market for biomaterial based devices, and some of these devices we will look at in a subsequent lecture this week when we look at a device perspective for biomaterials, where we will see that individual biomaterials like polymers or metals, etc., may rarely be used in isolation, but as a device they are typically integrated, and it is the device that eventually gets implanted, where you will have multiple types of biomaterials coming in, multiple generations of biomaterials meeting together. So, here what is shown here is the first number is simply the number per year, and the global market in US dollars is shown in parenthesis. And these numbers are mind boggling. You have along different categories like joint replacement, heart valves, stents, dialysis, breast implants, cochlear for the ear implants. All of these, the numbers that you are looking at simply indicate that this is a very, very, very large and booming industry. And what is also important to keep in mind that one or two of these could also be related to lifestyle based conditions, and those are continuing to rise, and so the need for these is only going to rise with time. Another way to look at them is to look at by domain, where we are looking at specific types of application domains like cardiovascular devices, orthopedics, urology and drug delivery devices, and you see just within 5 years what these numbers have grown to, as indicated by the CAGR. So, all of this should suggest to you immediately the importance of studying and understanding biomaterials both from a scientific perspective and a practical perspective. And in this course, in the upcoming weeks, we will be looking more and more into understanding how structure property relationships help dictate function and performance of the biomaterials in this very exciting set of lectures. Thank you.